Youth in Transition is the project. Of course, I would like to start my presentation, like the other speakers, with a big thank you. In the first instance, of course, for the funders, the King Baudouin Foundation, the fund Julie Renson and the Queen Fabiola Fund, for giving us the opportunity to do this chair. Also the experts who were willing to present here, thank you. And I would like to have a special word of thanks to the experts by experience, so the young people who will give a presentation or tell their story in the afternoon, because I think it's very courageous of them to be willing to speak here in English. So I think this deserves an extra big thank you. So what is transition psychiatry? One of the things I noticed when talking about transition psychiatry is that many people have many different meanings on what is transition psychiatry. There's one thing for sure, it's really hip. It's a bit of a hype, transition psychiatry. Even royals go through transition periods nowadays. But is it only hip, or does it actually mean something? I think what everybody agrees upon is that transition psychiatry, the most narrow definition of it is basically this. So managing the transition from child and adolescent psychiatry to adult psychiatry, with a lot of difficulties, of course. So at the very least, this is transition psychiatry. And for some people, that's all. Other people say, well, that's not all. It's not just about organization of services. That's just one part of it. We need to look a bit broader than that and look at, if you look at the incidence of mental disorders, and previous speakers have talked about this already, you see that 3/4 of mental disorders begin before the age of 24. So it's a important period. And why is it an important period? Because, as young people have to develop their social identity, separate themselves from their parents, their brain is developing, all things you already heard. So this is a very, let's say, promising period, but also a bit of a vulnerable period. So that's already two definitions of transition psychiatry, I would say. And the UK, for example, has really chosen to manage transitions within their model. The Australian model, for example, we will come back to this, is more like treating the people between 16 to 24 in specialized treatment programs. But then, of course, you have two transition periods. So we don't really know yet which is the best model, and if there's a best model for every disorder, or that we have to separate this out. It's not a new idea. So even before I was born, this already existed. So Jos Peuskens in 1973, I had to look back into the history of UPC KU Leuven. He started a transition unit for young people with psychosis, and actually treated young people from like age 15 or so. So already in 73, and then Dr. Lili van Bouwel took over in 1987. And 10 years ago, we started a community treatment team for young people. So clinically, this has been going on for quite a while. In Belgium, at the international level, this was a very influential Professor Patrick McGorry, who really installed this treatment all over Australia, and had a big influence on starting these kind of programs also in other countries. And the initial model they proposed was basically this. So they were more or less specialized in psychosis, and they tried to look after young people at a very early stage, even before they were actually clinically diagnosed with psychotic disorder, to treat them as early as possible. So that was basically the model, which is if you call it in scientific terms, a diagnostically siloed model. And so much of this clinical work was influenced, I think, by the work of Jim van Os. So I'm happy he's here with us today. Welcome, Jim. And in his group, where I was part of for, I think, 8 or 9 years, we worked on the psychosis continuum, which is basically stating that psychosis is not a clinical disorder, but has a distribution in the general population. And so you have different levels of vulnerability and expression of psychosis. And so if you put this in sort of a developmental model, this is what you would get. Jim called this the psychosis proneness persistence impairment model. So you have a certain vulnerability. This can lead to persisting psychotic symptoms, which remain subclinical. And then in some people, this may invoke a clinical transition or transition to a clinical disorder. So basically, what you see is that in adolescence, you have a peak of symptoms, also of psychosis, and also there's a vulnerable period. And so what we try to do over the years is basically showing that this is not just a model, but is also reflected in clinical reality. And so this is a study, for example, in 16-year-olds, where it was shown that really psychotic experiences are highly prevalent in normal developing adolescents. The ever and often categories, you see quite high percentages. So these are Dutch adolescents. This is a study published last week describing the symptoms or the incidence of psychotic experiences. And you see that the predicted model was actually, I think, confirmed. So this is basically how psychotic experiences develop over time. This is work we did with Hanneke Wichman, who is now in Groningen, trying to investigate over time how these symptoms develop. And you see this especially here. These are more or less subclinical groups that may further go on to develop psychotic illness. And if you look at risk factors, you see the classical risk factors, of course, cannabis use, etc. And you see a big influence of traumatic experience. So this has been a focus of my research the years after. We also looked at transitions from, let's say, the mildest to more severe psychotic symptoms. So these are psychotic experiences that people themselves say, yes, I have these experiences once in a while. And these are symptoms of which clinicians say, yes, this is truly a psychotic experience. So we looked at transitions from one to the other. And, well, what we found is that, of course, people who have self-reported experiences have a higher risk of developing validated psychotic experiences. And this is what we call homotypic continuity. So symptoms of a particular disorder predicting transitions to a clinical disorder. So if you want, this is another level of transition psychiatry, really studying transitions along the axis of subclinical mild symptoms to the development of actual disorders. There's more, however, which is this, in that this didn't just predict transitions to more severe psychotic symptoms, but also to other psychiatric disorders, for example, mood disorders, anxiety disorders, etc. And this is not just one study. This is a study published, I think, 2 months ago in JAMA Psychiatry, where the Australian model was tested, and they assigned clinical stages to their adolescents and young adults presenting with anxiety, mood, and psychotic symptoms. And so they investigated transitions between non-specific stages to attenuated, so milder symptoms, to actual transition to a clinical disorder. And also there, you see that psychotic-like experiences we're actually the strongest predictor of transitions, not just to psychotic disorder, but to any mental disorder. There are a few other significant predictors, of course, age, because this is a time effect. The longer you're having symptoms, the more likely you will have a disorder, and a few others, but not many. And so, yeah, the model which is used nowadays is not a diagnostically siloed staging model, so you don't stay within a given disorder. So actually what we say is we don't really know what their diagnosis of young people will be. They have very unique patterns of psychopathology that are very typical for a given person, and only over time will we know if they will develop a disorder, and if they do, which disorder this will be. And I think this is an important lesson that has been learned from the Australian model, that not just what we call homotypic continuity should be studied, but heterotypic continuity is actually as important or probably more important. So, and also the clinical model we need is really this one. And so this is why, for example, the International Early Psychosis Association, IEPA, is now not called International Early Psychosis Association, but it's called the Early Intervention in Mental Health. This is really reflecting this, we don't know what will happen in the future, we want to take care of your symptoms as they are present here and now. And Therese van Amersfoort will, at least I assume she will talk about her experiences in providing this type of healthcare, which is in Australia coined Headspace, and in the Netherlands there is an at-ease house, which is basically the same model, and in Amsterdam there's one as well. So this is Therese, and this is Sophie Leidersdorp, who is a PhD student investigating this program. So if we want to examine transition psychiatry, I think there are different levels we need to study. Of course, we need to study transition of services. We also should try to provide specific age-adapted treatments that are adapted to the transition phase. And then more at a fundamental level, we need to really study how transitions from clinical or from subclinical to clinical emerge, and how transitions from undifferentiated to differentiated symptomatology emerge, because this is what will lead us to the clinical work in 10 years, I think. So, just to go over how the chair of transition psychiatry in Flanders will try to do that. I have to say, not all of this research is funded by the King Baudouin Foundation, but all of it is under the umbrella of the chair of transition psychiatry. So, for one, KU Leuven was part of the Milestone project, which was really the project examining how transitions in young people are actually happening right now in the clinic. And this was the work of Piet Tremmery, a child psychiatrist who worked in KU Leuven, and Gail Hendricks, a PhD student. And KU Leuven was responsible for the training work package. And so a number of papers have already come out. And they're not really encouraging right now. So, for example, only in 2 countries transition is part of the training of young trainees in psychiatry, and only in child and adolescent psychiatrists. So this is an issue, and if you ask European trainees, do you need more information, do you need more training, 94% of them says yes. Yes. So only 27% says, no, I have good knowledge about transition. So this is clearly a problem. It's, well, suboptimal may just be a euphemistic term to describe it, I think. So education and dissemination will be a vital part in what we will be doing. We will, of course, train the trainees, and we will discuss with the other universities, because this is an inter-university course, to really integrate this into the training package, of course. And we will also provide all the information we can give, like reports, but also the presentations of today. We have a video camera recording all presentations. This will be all on this website here, so youthintransition.be. Everything will be freely available, so please check once in a while to see the progress of the different projects. So, what will we be doing next is really trying to go to the bottom of what is a good approach to mental health care. So there are different models. We've seen this in different developed countries. We don't really know which one is best. We may have some preferences. But I think we need to study a bit more what is really what we need. And so we will ask a number of questions, and the important thing is we will ask young people and we will ask professionals. So, for example, what is helpful when you're experiencing mental health problems? What approaches would you need? And this is not just clinical, any approach. You're talking to a friend, being able to call someone, consulting things online. So very, very broad, not just the clinic. And we hope to learn a lot from young people how they would like to be, supported with their problems. We will also, of course, ask professionals, and then we will ask in a second survey what are barriers to mental health care. What stops you? How do ideal services look like? And again, in young people and professionals. And then the final part is what are differences between young people and professionals, and then doing a Delphi study. So a Delphi study is basically bringing together all the opinions of both young people and professionals and trying to, over time, come to a sort of a consensus statement to really, provide concrete policy recommendations. So that's the idea. PhD student will be, or is Eline Wittevongel, and this is together with Marina Dankaerts. And so, as you may have learned, we will work together with people from the field. So we already have a number of people who said, yes, I would like to be part of this. We invited a few more, and so there are still vacancies left. So if people want to contribute, please contact us. We will also have young people, of course, in this expert team. And we intend to work together also with the networks. We have a meeting next week, so I'm excited to learn about their ideas. So this is basically what we will be doing, and this team will be integrated in how the research will be set up, in the recruitment, dissemination, the organization of symposia, of course, if they're willing to do so. At least we are willing to really involve the field and people interested in transition psychiatry in this project. Okay. Third big thing we will be doing is trying to provide age-adapted care. And we decided to focus on social interaction problems because this graph is from a study we did in Flemish adolescents. And what we very clearly saw is that social interaction problems were a major driver of mental health complaints. And we think that this is a transdiagnostic problem, so it's not specific to any one disorder, and we can really help young people train this. And we thought this is a good way of training. If you can do this in virtual reality, you really can control the environment, you can control the interactions, control the people, and work slowly towards, real life. And so we have the software since December. We have trained psychologists since December, and so. This is not a patient, this is actually a PhD student of mine, Victor Mazeril, and this is not a therapist, but a computer developer. But just to give you an idea of how this will look like, so the therapist can really control what is happening in the virtual reality, can control gestures, can control expressions, can control what people are saying, so can talk to the patients through a microphone. You can choose the characters, you can choose the environments. For example, this is a street, this is a bus, which many people find very intimidating, and you can really vary in the level of intimidation, so you can have strange characters like this one in the front of the bus and will be staring at you, or so it's really, I think, a new way of approaching mental health problems. And there is some evidence also that it works, that's helpful. So this is from the group of Wim Veling and Mark van der Gaag in the Netherlands, who published just last year that this really helps to reduce paranoia and reduce social withdrawal. So what we will be doing is basically implemented this clinically. The scientific part will be more of a feasibility study. The major goal is really implementing this in the clinic. And we will ask people, if this works for them, and of course, how they experience the virtual reality environment. Okay, and finally, I think we don't just need very, very applied clinical research, we also should remain focused on finding new models, finding new methods, finding new treatment approaches. And so what we will be doing is two things, basically. We will have an epidemiological approach and a neurobiological approach to really study how symptoms develop in adolescents and young adults in Belgium. So to start with the epidemiological approach, so we work together with Ines Germijs, who is also a professor in KU Leuven and the PI of a very large study in adolescents. So about 2,000 adolescents have now been tested between 12 to 16. And the first reports is around 20% have moderate to severe mental complaints. And as I've shown you, these are highly correlated with, social skills. So this is just the very first reports. Papers still have to come out, and we have to start studying this cohort still. But this will be a main part of the chair. My team will especially focus on social developments, since this we think is a very important problem. Identity formation in these youngsters, and of course, because this is a very important thing, childhood trauma. The next big epidemiological cohort which we will use is the student cohort, so the Leuven College survey, which consists of around 15,000 students that are followed up yearly. And again, we will focus on social development, connectedness, and childhood trauma, really trying to investigate how symptoms emerge in these young adults. And then finally, we have a neurobiological approach. Again, we will focus on childhood trauma. Well, why childhood trauma? First, this is a very important risk factor. It's also a transdiagnostic risk factor, and we and other groups have really reported that it's not really useful to look at individual disorders, I think, because what you see is that trauma really leads to specific alterations in the brain that are associated with specific symptom expressions. So people with trauma often have comorbid symptoms of anxiety, of depression, of psychosis. And so what we will be studying is how in traumatized adolescents and young adults, what are the brain alterations and how do they lead over time to symptoms of psychopathology. So there's basically two studies. This is the model we will be using. I won't go into details. This is too complicated to tell you in 5 minutes. If you're interested, you can read the paper. But we will focus on a specific structure in the brain, the hippocampus, and how this relates to psychopathology. And so the first project is in 12 to 16-year-olds, where we will study this this model and then follow them up after 2 years. The second one is in 16 to 25-year-olds who already have psychiatric complaints, and there we will investigate physical exercise as an intervention, because we know from the animal literature and very limited human literature that you can actually improve this hippocampal functioning by physical exercise. So we think physical exercise is a really good intervention in these young adults with trauma. So that brings me to my conclusion slide. So we're working together with a big group of people. We still have vacancies left in the expert team. We have a vacancy for a PhD student still, etc. So I'm looking forward to working together with all these people and maybe some more. And I would really like to thank my PhD student, Eline Wittevormel, the other ones as well, of course, but specifically Eline, because she did a lot of work in the organization of this event. So thank you, Eline, and thank you for listening.